you.
That's why she's there. She's keeping me right with all the right buttons to click.
I know that feeling.
So we're probably okay. I'll formally start us in just a second so I can see our attendees. Welcome back if you were in our last session, and if you're just joining us, it's wonderful that you're here today. Our next speaker for our Parenting and Mental Health conference is Alan Guthrie. And Alan, you and I haven't met actually in person, but I have heard wonderful reports from Michelle about how supportive you have been, particularly to the parent rooms, but just in the whole area of mental health and well-being for parents. So we're really looking forward to what you have to share today and what we can learn from you as we continue to work in collaboration. Do you have a PowerPoint that you want to share?
I do indeed. I'll share that now.
If you want to share that, and then I'm going to put my video off so that you have the full screen, and then I'll come back on at the end. And just remember, panelists, if you want to ask a question or make a comment, please feel free to do that, and we'll try and pick those up at the end. But Alan, thank you again for joining us, and I'll hand over to you now.
Oh, thank you very much indeed. And thank you for that very kind introduction. I have to say that the support that Michelle and formerly the PANGs, now the parenting rooms, has given us has been superb. And it's a real pleasure to be here. Thank you very much indeed for inviting me and giving me the opportunity to speak with you today. The development of perinatal services in the last year has been phenomenal, right from the minister's sort of announcement in January about the new funding, which is, is very, very welcome and arguably long overdue. But I know the department have been working very hard in terms of trying to ensure appropriate perinatal services. So the momentum this morning, and having listened to some of the presentations as well, is excellent, and the energy around the issue is excellent, and the speed at which both community and now more so sort of trust services are developing in this area is excellent and really, really positive. So folks, my name is Alan Guthrie. I'm the social work lead for the West Belfast GP Federation multidisciplinary team. Now what I'm going to do this afternoon, time flies, is just give a quick snapshot of what an MDT is and the development of MDT, talk about the aspects of the MDT, and then bring the focus a wee bit into the social work role, because obviously that's my forte, if you like, in terms of my focus. So if you have any questions, please feel free to ask. I may not have the answers because I have liaised with my colleagues within the MDT, both from Health Visit and Mental Health, who have fact-checked this presentation for me as well. So if I don't have the answer, I will certainly seek the answer and get back to you. So the need for perinatal care services very much well established, not only generally in terms of the experience of individual mums and families, but also in terms of reflected on today's conference. So this is just sort of a statement in terms of the Royal College of General Practitioners and the recognition of the need. As you can see, up to 1 in 5 women and 1 in 10 men are affected with mental health problems during pregnancy in the first year after birth. Only 50% of these are diagnosed, so that's a huge, huge issue to begin with. And without appropriate treatment, the negative impact of mental health problems during this period can be enormous. I'm a parent, and I do recall the first year, especially with my son, my first child, and it's chaotic in its own right. Trying to adjust your life, the parenting, and the whole introduction of a new life into your family, what that must be like if you're also unwell. I just can't begin to think, and how mums and families come through that is testament to the courage and the energy and the strength that people have and families have. So again, it's excellent that the minister's introducing that tiered stepped model. I think that'll really help. And I suppose as a primary care social work lead, I'm extremely keen to look at what we can do as social workers in primary care to support parents and families who may find themselves in this situation. Because the key, as the statement at the bottom says, it's not inevitable that people will have long-lasting consequences. When problems are diagnosed early, treatment offered promptly, the effects can be mitigated or lessened. So some of the challenges and barriers for parents. This information has been very kindly given to me by my health visiting colleagues within the MDT, and it may be very, very familiar for some of you who have been in this situation and experienced perinatal mental health problems. So these will be well known in terms of the stigma and fear of being labelled or judged. And not to go through the whole list, but just pull out some of the real pertinent issues unable to access GP services on the same day. Obviously, COVID has had a huge impact on this. And Michelle talked earlier about feelings of isolation, loneliness, and stress through COVID for parents and for mums suffering from perinatal mental health problems. I know nothing about perinatal mental health problems. Touch wood, fortunately, myself and my family have experienced those, but I can only imagine that those feelings of isolation, loneliness, and stress are probably a common feature if you're in this situation, whether in COVID or not. And that's key in terms of being able to access services. GP colleagues work very hard, and the MDTs born out of Bengoa are being put in place to support primary care, to try and lessen the pressure on GPs and to provide a more holistic response to people in their local community. So the services, I'm going to talk about this later, the services are accessible directly. You don't necessarily have to go through the GP to see the social worker, the mental health practitioner, or your physio in your local GP practice. Some of the other points as well, waiting lists for support services, therapeutic interventions are getting longer, and there's limited support in the meantime. So that's absolutely fabulous to reflect on Michelle's discussion this morning about how the parent rooms is evolving and developing, both with Castlewell and in Belfast, but also regionally. When you look at the map with the pins in it in terms of where there are services, it's really, really heartening. Insufficient or poor follow-up post-discharge, lack of services for fathers. Again, that was discussed as well in terms of, and I know the parent rooms are very much focused on that too. And then parents with perinatal mental health problems have reported that they can find virtual telephone contact difficult to engage with. And again, it's good that the Minister this morning has announced new funding to support GP practices in terms of increasing direct visits. So whilst these are the challenges and the barriers, my health visiting colleagues are also very keen to point out there's lots of green shoots and ideas to explore improvement. And this is some of the ideas that have come from health visiting colleagues within the Federation. To have a central directory where information relating to perinatal mental health can be kept or retained. It includes referral pathway criteria, contact information, who to refer, and whom and where to offer services. I think one of the key things, when you find yourself in any situation related to your health, the key things that you want to know really are, who can I contact? How can I get support? And can I talk to people who've been in this situation before? I think talking to people who've been in situations before is absolutely crucial in terms of giving parents and mums that support. Keen for an MDT approach to perinatal mental health service, not only within primary care, but locally and regionally as well. Annual training in a multi-agency format by perinatal mental health professionals. A robust system of communication to ensure that the right services in the right place are delivered at the right time and be able to work together effectively. And again, certainly from a personal experience, having come into this post in April 2020 and having made contact with the parent rooms last year, being able to work together makes a huge, huge difference. Being able to have good communication and, more importantly, for individuals to be able to have access to the services that they need is absolutely key. And the links with the parent rooms have made a huge difference to a number of individuals within their GP practices within West Belfast. Finally, and more importantly for me, personally speaking, as a steering or expert by experience group for mothers and families who are keen, who have been involved in perinatal mental health to help guide decision making. Again, I think the parent rooms in the development of it and the development in terms of the focus from the Department of Health and the Minister really sort of says it all in terms of how important this issue is and how it needs to develop in terms of the support services available. Okay, so folks, that's just a bit of sort of background from my perspective as a social work lead in the West Belfast Federation, but also from the perspective of my colleagues in the Federation, both in terms of health visiting and mental health. And so what I want to do now is just to move on and talk a bit about the MDTs and what they are and where they're based and where the idea came from. So MDTs really were born out of Professor Bengoa's review in 2015 and then the subsequent strategy by the Department of Health called Transforming Your Care. Now, Transforming Your Care will run to 2026. And the whole point of the MDTs, as I talked about earlier, was to bring greater support into primary care so that people using their local GP practices can access services quicker and more directly, and at the same time to support primary care in the development of services at a local level. This allows the GPs to free up time for GPs to focus on those areas we all want them to focus on, those clinical and critical care need areas, whether it's COPD, diabetes, perinatal presentations, those clinical areas, and then to give them the team and the MDT support within their local practices to provide a more holistic service. So it sets an ambition for people to be supported to keep well and take control of their own health, have access to safe, high quality care when they need it, and have care delivered by staff who are empowered and supported to do what they do best, and that the services are efficient and sustainable. So purpose of the MDTs, I've sort of touched on this already, train up GPs to deliver what they're trained to do, but also to deliver more effective, focused and timely patient care by appropriately trained professionals. So the MDTs, there are 17 GP federations in Northern Ireland. So West Belfast GP Federation is one of those federations. Within our federation, we have 16 GP practices. Within each of the practices, there's now an MDT, a multidisciplinary team, and that's made up of the practice staff. I'll move forward actually on the next list. It's made up of the practice staff, the GPs, the GP staff, the treatment room nurse staff, and other staff. But also the MDT have brought in a pharmacist, a physiotherapist, a senior mental health practitioner, a senior social work practitioner, enhanced health visiting, enhanced district nursing, and physio. So it's quite a significant change in terms of the services being put into primary care. Now, the physiotherapy service, the senior mental health practitioner, and the senior social work practitioner can be accessed directly. So you can go to your local practice and access and ask to speak to those professionals directly without necessarily having to go through your GP. Now, within West Belfast, as a consequence of COVID, understandably, the full social work model hasn't rolled out across all 16 practices as yet. We're currently in 5 of the 16. But in time, it is envisaged that the model will be rolled out across every GP practice in Northern Ireland by 2026. Now, we'll wait and see if COVID delays that slightly, hopefully not. But certainly it is the focus and the policy of the Department of Health. So it's really to enhance support in primary care and to reform our community and hospital services and move away from a model focused on dealing with ill health to a model focused on mental, physical and social well-being. So I've already touched on the MDT and how it's made up in terms of the practice staff. So just to go into some of the roles, in terms of the physiotherapist role, they're called first contact physiotherapists, and up to 30% of patients presenting to GPs in primary care have an MSK problem, a musculoskeletal problem. So the whole point of having the physios on site is to allow folk to be able to access that service much quicker. And the physios are within the practices have an expertise to act as first contact practitioners. So they're able to assess, diagnose, manage and coordinate an individual's care, both at a local level and when necessary and required into secondary care and more specialist services. Their role is to promote self-care, health promotion, wellness behaviours and utilising local services to help deliver to the patient. Okay. In terms of the senior mental health practitioners, and it's in another sort of new concept, if you like, within the MDTs, is it's made up of a different model of how the services are provided as well. As you can see from my banners either side of the presentation, I work for the Belfast Trust and the Federation Resource and working within the Federation alongside Federation colleagues. My senior mental health practitioner colleagues are Federation employees. They're employed by the GP federations, as are my pharmacy colleagues. My physio, health visit, and district nursing colleagues are all trust employees. So you can see that sort of partnership working. And key for us, and again, I'll go on to talk about this in more detail shortly, but key for us as a social work service is that the social work staff, and alongside the senior social work practitioners, there's also social work assistants, spend 50% of their time working in the community and voluntary sector. So that's out of the practices and working alongside community partners, community colleagues, and voluntary and community partners as well. So the senior mental health practitioners, their first contact as well. So staff, individuals can go in and ask to speak to them directly without having to go through their GP. They provide assessment of mental health needs, delivery of brief interventions, and relationship-based approaches. So they work collaboratively with the whole practice. The MDT work together with a view then to wrapping around individuals as they present, because we're all complex in our own ways. And usually if somebody has a mental health problem, there's usually social work related issues. There may be physical health in terms of the need for physiotherapy. There may be nursing needs. There may be a whole complex, because we're all complex, range of needs there that hopefully the MDT can collectively address. They have also a function in terms of educating and raising awareness in areas of mental health and well-being. And you can see some of the interventions that they use to be able to do that in terms of the psychosocial education, peer-led education as well. And then they also adopt community development approaches to be preventative, and also to provide early models of intervention. And that'll fit really in terms of the new model of practice in the step one tier of the tiered service that the department are now progressing in within each of the trusts, specific for perinatal care. And the nursing team, or nursing colleagues within the MDTs, their objectives are to reduce the gap in district nursing staff levels and hence normative staffing levels, to sort of have a district nurse available within each of the practices, and to improve the safety, quality and experience for patients and staff, promote a key worker role, which I think is key in terms of having an individual who you can build a relationship with, who you can engage with, and who you know within your local area, your local practice. To support on scheduled care agenda. And I know my district nursing colleagues now are full on in terms of the current vaccination clinics and supporting the practices in terms of making sure that everybody in the population gets access to the vaccination, particularly those individuals who are shielding and who are at greater risk. And also another key issue as well, another sort of new sort of innovation, if you like, is to remove boundaries across Belfast with GP alignment. And I work in the West Belfast Federation, and two of our practices are in the South and East Trust. And the really healthy thing from my point of view is that we work to the boundaries of the Federation and not to the Trust. So that obviously creates greater communication, interaction and involvement, working together as well between trusts. So in terms of the health visiting service, the health visiting service, as you know, is universal home visiting. It's all of the health visitors are registered nurses and midwives, and they've got additional training sort of in specialist community and public health nursing. And within the MDT, we all work very closely together. The senior team and sort of my health visiting lead colleague would be sharing the same office with me. So in terms of working together and looking at sort of the broader issues and broader topics, that's key in terms of developing interventions and making sure that we're providing as good a service as we possibly can. So the health visiting service delivers a programme of care to promote, protect physical, emotional and social well-being of individuals and their families. So their overarching aim is 100% completion of the Healthy Child, Healthy Future contacts, 100% completion of the 3-year health review, and to provide additional early interventions. And their role is absolutely key as well in terms of early intervention, prevention and identification where mums, parents and families may be struggling as a result of perinatal mental health issues. So folks, I'm conscious I'm zipping through, and I know there's 2 chat functions here, so maybe just visit those quickly. Okay, can you do a self-referral for kids with disability? I will actually, I will follow up with these questions if that helps. Yeah, in terms of the social work service, we have come across a number of situations where parents and families are struggling in terms of the waiting list for autism spectrum disorder assessments. We are looking at that in terms of primary care and trying to provide as much support as we can at a local level for parents and families. I understand and appreciate the waiting lists in terms of both the trust services and also in terms of education services are significant. And there is a key role, in my view, within primary care to look at how to support families initially when the first assessment, and then through that referral pathway and the journey then that folk have to take in terms of waiting for assessment. Okay, folks, so the social work role. Oh, the screen's frozen. The vision for social work and primary care, and I've taken this from a GP, which is always a good way to try and integrate with GP colleagues and primary care colleagues in general, is to fuse services and implement innovative and creative ways of working to ensure that communities are empowered and patient care and safety remains uncompromised. So let's discuss the elephant in the room in terms of people's perceptions of social work and the social worker role. As you can see, some of the descriptors here, in terms of some of the key ones, I think for folk in terms of concerns about social work and working with a social worker is in the bottom left in terms of what people think I do. I suppose the key here for me as the social work lead is that the sharper end of those social work interventions in terms of safeguarding, whether it's in relation to childcare or indeed to adult safeguarding, the social workers within primary care, that is not their specific role. Safeguarding, as you well know, as I'm sure you know, is the responsibility of every health professional in primary care settings. It's the responsibility of colleagues involved in the care sector and also community care sector as well. And the processes and procedures and local arrangements that are put in place in terms of safeguarding teams are there for everyone to contact. So that's not the role of social work within primary care. Certainly safeguarding is a key focus for us. It's one of our key sort of aspects of our role in terms of supporting people who are potentially at risk or who do have a safeguarding issue. But the whole MDT have that focus as well in terms of ensuring people are safe and well. So I suppose what I'm trying to say is that in terms of this is a real opportunity for me as a social worker and for the social work profession. Social workers in primary care work with everybody in terms of all age groups and all presentations. So it's a very generic role. And they'll go on to talk about the key focus for social work, but the aim is to support individuals at primary care level. And key to that would be the social worker's ability to advocate on behalf of individuals coming into the practice as well. So what does social work bring? In terms of the role within primary care practices, it's a right and strengths-based approach. So everything that is done in terms of an individual's access to the social worker in their local practice will be done by consent. It's personalised responses provided in a confidential manner. We empower individuals and support individuals from their point of view, as well as help in terms of any issues that may be required in terms of protection. And again, that's about safeguarding. We encourage individual control, so people take responsibility and control of their own lives, independent lives as active citizens, to ensure that any interventions provided or any support provided is least restrictive and in least institutional settings. We will continue to review outcomes with individuals that we work with and look at more inclusive options. And key to that is the fact that each of the social workers within the practices spend 50% of their time directly engaged with the local community. So working alongside our community colleagues. And the key element of that for me is making sure that the service is properly integrated. And what that means is making sure that when we align with the local community groups and the local voluntary sector, that we do so in a manner that respects the excellent work that they have done and continue to do, and also the quality of the services that they provide. And well, to be honest, if social work is to work in primary care, one of the key factors that will measure that outcome will be how successfully we're able to walk alongside our community colleagues and our voluntary sector care colleagues as well, and how well our relationships, communication, partnership working, and integration combine. And for me, the key measurement of that will be the measure from the point of view of the people that use the service and how they viewed it and how they've seen it and their experience of it as well. Another key element for the social work model and social workers is achieving social justice and making sure there's a reduction in inequality where inequality is identified. And that can be about access to resources, that could be about any number of issues in relation to an individual's personal and social circumstances. And more importantly, overarching, you realise the contribution of social work to improving the efficiency and productivity of service. And what that means is making sure that, that if people need the access to the service in their local practice, that they can do so in a manner that's timely and in a manner that makes sense to them. So in terms of how social work and the culture of social work and the continuing change, social work is moving away from paternal sort of role into personal. So the support that we provide as social workers is built around the needs and outcomes of individuals as they see it and from their perspective. Prevention is acting earlier and as soon as we can in terms of supporting people to prevent and reduce needs and to help people stay well for longer. Integration, trying to make sure the services are joined up and we work as partners across local communities and benefiting the whole population. And to be inclusive, working with people and communities, develop shared solutions, doing with, doing alongside. So, as I said earlier, we are at the early developmental stage of the MDT within West Belfast. Social work has been sort of came in January 2020 at the very commencement of COVID. The department have rightly frozen recruitment to new projects on the basis of the need to respond to COVID. So we were able to get 5 of our staff in and 2 of our social work assistant staff in prior to the recruitment having to be frozen. Hopefully we're coming through that now, coming out the other side of that. Hopefully within the very near future, we'll have a social work service within each of the practices within West Belfast. And equally then the model will roll out across all of Belfast. So by 2026, there will be an MDT model, an MDT service in each of the practices within Belfast and indeed within each of the GP practices across Northern Ireland. So within the practices, the social work role certainly will be supporting individuals to address factors impacting on their health and well-being, assess and address the social detriments of health. So social worker will support individuals in the round, not just a particular specific clinical care pathway, but looking at people's living and working conditions, their family and community relationships, social and economic circumstances, and environmental factors. We'll also be supporting individuals to address adverse childhood experiences and a trauma-informed response. And again, Michelle reinforced the importance of that as well in a previous discussion earlier. Minimise preventing these issues adversely impacting upon health and well-being. Part of our key role is, as I said, is safeguarding individuals and their families where safeguarding concerns are brought to us or raised. And then supporting general practice, and as it embeds, helping to focus resources and ease some of the work burden for our GP colleagues. And then overarchingly supporting and contributing to the community development and helping to build resilience and supporting local health strategies. So how we do that really is through assessment, planning, safeguarding, advocating on behalf of the individuals who come to use our service, supporting access through that advocacy, whether that access is within their local community, their local voluntary sector, within secondary care services, or indeed within the primary care practice, with regards to potential access to one of our other MDT colleagues. We also develop services as well, and we were very fortunate to be able to work in partnership this year with the parent rooms in terms of providing support for mums and dads to be able to access the parent rooms services through direct referral from GP practice, which was excellent. Has been really, really good. And then developing services as well. And then review and outcomes in terms of people's experiences of those services. And I suppose going back to my very, very first slide in terms of the fact that 50% of mums and fathers who are suffering perinatal and poor mental health aren't recognised. So there's a lot of work for us to do there in terms of raising awareness as well, and generally across society, but only within practices as well. So some of the examples of what we've done to date, we have a certain amount of funding, which is called seed funding. And that seed funding is to be used really to identify what there are gaps in primary care, not just for social work, but for primary care in general. The seed money can then be used to try and identify and address those gaps. And the whole point of the seed money is to sort of early starting, and then looking how, if a project starts through seed money, how that then evolves and develops, and how we're able to grow it, and what the exit strategy might be for individuals who may attend the seed funding project in terms of linking them in with other groups or other types of supports. We were able to work in partnership with a number of community and voluntary sector colleagues through COVID, working in partnership with Women's Aid and to create awareness and promote access to services for people within their practices. We're integrating the services within the community care hub, and we're contributing to the West Belfast Building Resilience and embedding wellbeing strategy. And again, we're using the seed funding to help us address some of the gaps that are appearing. So folks, this is where we're getting near the end. So some of the key learning for us, and we're learning every day, which is excellent. But the clear communication and shared vision is absolutely crucial. I suppose that's why conferences like this are so important, and so worthwhile and so useful. Partnership working and that collaborative leadership. So it's looking at engagement in the context of perinatal care, for instance, across primary, secondary, community, and voluntary. So that tribe, if you like, that village, and again, that's key as well. New relationships and developing and enhancing the MDT teams, sharing the learning and helping it roll out both locally and regionally, and finally building relationships and networks. And again, this conference is absolutely key to that as well. So the last slide really focuses just in terms of where our next steps are. So it's to discuss and address implementation challenges and have those courageous conversations. It's to continue to engage and develop partnerships, measure the outcomes of those, and also implement appropriate governance and quality improvement frameworks. And governance and quality improvement frameworks are key because they measure how effective your service is or isn't, but they also, based on the experiences of the individuals that use those services, give you an opportunity to ensure that the quality improves, because quality continually improves and has to continually improve, because if it doesn't, then your service is just standing still. So folks, thank you very much indeed. Hopefully I haven't gone through those too quickly, but certainly if there's any questions.
Thank you so much, Alan, for that. And thank you also for keeping a wee eye and answering some of those questions as we went through, because that was really helpful and really timely. And you did actually answer a couple more questions that had come through privately to me around sort of the role of social workers and how to encourage parents about what that role is. So that was really helpful. And those people have come back to say thank you. They just wanted to ask that question privately, but thank you for answering that and what you shared as well, because I know that was really helpful. And I particularly learned so much from that, and I loved your comment about always learning, because that's exactly the same for us. I think if we all come to everything with that attitude in mind, that we can always learn something, actually we can all do much more together, and we can actually work collaboratively if we're actually willing to learn with and from each other. So thank you. And there's some lovely comments in there. Hopefully you can get a wee read of them to thank you for your presentation and for all that you have shared. And we look forward, particularly from the parent rooms, to working with you more in further days ahead. So thank you again so much for joining us. Thank you for what you shared.
No, listen, I really appreciate the opportunity, and I've really enjoyed working alongside the parenting rooms, and it's an absolute pleasure to see how quickly it's evolving and how quickly it's developing in the context, not only in its own right, but also in the context of the policy and strategic developments for what is a very, very important issue in relation not only to individual health of mums, but their families and society in general. So it's an absolutely key area, and it's really, really great to see so much momentum and energy behind it. And folks, my email address is there. I'd be more than happy to take any questions after this or follow up with folk in terms of any information anybody might need. But thank you so much for the opportunity and being part of the conference, and good luck with the rest of it as well.
Thank you, Alan, so much. And yes, please do take his email address for anyone who would like to ask any further questions. attendees, the link for our next talk, which is Maria from the Perinatal Health Alliance, is there. So if you click on that, I will see you through in that talk in just a minute. And thank you again, Alan, very much.
Thanks very much.
Bye.
All the best. Thanks. Bye-bye now.